All right. So welcome everyone. Thank you for coming out in the evening during our prime hours after work. Um, we are very excited to have Dr. Allison Schroeder here tonight to talk on the Achilles tendinopathy, and certainly affects our runners. So we'll get some good tips from her today. This is our last session of the year 2024. We've got quite a few folks already lined up for 2025. And of course, I'm always open for suggestions if anyone's got speakers that they'd like to hear about or particular topics. Um, I will be sending out an email relatively soon to give you a list of some of the upcoming sessions. And then we'll also have a session too that will be an opportunity for us all to have a little bit of a community network session also. So stay tuned for all of that. So without further ado, I'm going to introduce Dr. Schrader here and then let her get started. As always, we'll wrap up with around about 15 minutes or so of questions. So as you think of questions, throw them into the chat and hopefully we can have a good discussion at the end. So Dr. Allison Schroeder is an assistant professor in the Department of Physical Medicine and Rehabilitation and the Department of Orthopedics at MetroHealth Rehabilitation Hospital in Case Western Reserve University in Cleveland, Ohio. She serves as the Associate Director of Musculoskeletal Medicine and the Director of Ultrasound and Rehabilitation Medicine. Dr. Schroeder's clinical and research interests include sports ultrasound education, diagnostic and interventional sports ultrasound, and the care of endurance athletes. She's a former Division I middle distance runner at the University of Notre Dame and currently runs recreationally. She enjoys caring for the runners and triathletes in the Cleveland area. And without further ado, Dr. Schrader.
Awesome. Thank you, Dr. Reiser. So I'm just going to get started. I don't have any disclosures other than the fact that I am a runner who's had Achilles tendinopathy, and I'm married to a runner who has had Achilles tendinopathy. So this definitely is a topic that is close to home. We're going to talk about anatomy, some of the brief clinical and pathophysiologic factors. I'm not going to talk a lot about, typical history and physical exam. We're kind of moving beyond that. About the diagnostic evaluation, and then some treatment options, including my preferred treatments in runners. So this is not an uncommon case in my clinic, a 31-year-old female. She was a former college runner, now running recreational marathons. She's had 10 years of left Achilles pain, achy pain over the Achilles mid portion that has gotten worse over the last 3 months to the point where she's had to stop running. She comes in saying she's tried everything conservative over the years. She just wants to get back to running, and she wants to get back as quickly as possible because she has a marathon in less than 16 weeks. So, this is not uncommon where I see someone who's just tried resting for a long amount of time, and then they come in when their like back is against the wall in order to build up for a training cycle. So, here we are, and we're going to just kind of keep that case in the back of our minds, and we'll loop back at the end. Thinking about the Achilles tendon in general, whenever you're thinking about the pathophysiology of something, you should always go back to basic anatomy. So we know that the tendon is made up of fascicles that are made up of fibers, made up of fibrils and microfibrils. And in all of our tendons, there is some vascularity to them as well. From an anatomy standpoint, I was taught in medical school that the Achilles tendon is the medial and lateral gastroc and the soleus, and it comes straight down and attaches onto the calcaneus. But the anatomy of the Achilles is actually rather complex, and the tendon twists upon itself. So these are images of a left Achilles tendon where everything is labeled as GM is medial gastroc, GL is lateral gastroc, and then soleus. And you can see that there's a significant amount of twist to the tendon. We haven't fully identified if this puts some people at higher risk than others, but it's interesting to keep in mind, what portion of the tendon is abnormal if we're looking at it and what's involved. And sometimes when you're doing rehabilitation, you can load one side of the tendon over the other with some different movements of the foot with the therapists and things. So the anatomy of the tendon is just not in a straight line. There are 3 different types that have been identified, with the type 2 being the most common. So this is several papers that have looked at the different types. I apologize, type 1 is more common. And that's where the twist is less versus type 3, where the twist on themselves is significantly more, where the medial gastroc comes far lateral and the soleus almost comes more posterior. There have been several studies that look at Achilles tendon anatomy and performance. And when I think about this, I just think about Kenyan distance runners who have a very short calf muscle and a very long Achilles tendon, where that longer Achilles tendon has better running economy. From a marathon performance standpoint, soleal volume, cross-sectional area, and then the thickness of the Achilles tendon and the soleus muscle to tendon ratio are all higher in those that have better marathon performance. And these might be adaptive changes that we're finding. And also we might be seeing that a lot of runners who have marathon for a long time and are better have developed some Achilles tendinopathy over the years that has correlated with this thickness, but that has not been fully elucidated. So just thinking now about pathology, a tendinopathy is a clinical term that's characterized by pain, decline in function, and reduced exercise tolerance. And it's actually on a spectrum. This is an overuse injury. We think that it's caused by repetitive microtrauma. And typically things range from tendinitis, tendinosis, and then eventually we can get some degenerative tearing. And you can see bony changes as well in the Achilles tendon with enthesitis and calcific tendinitis. And these are all kind of on the spectrum of Achilles tendinopathy. I think there's a lot that we need to learn when we're thinking about treatments of these because they likely all don't behave the same and may respond to different treatment options. But again, not something that we've figured out to date. From an epidemiology standpoint, Achilles tendinopathy is common. So 10% of all runners, up to 50% of elite runners, and symptoms persist for more than a year in 30% of people. So this is often something that people can ignore for a little while, and at some point it'll get bad enough that they'll present to your clinic. From a risk factor standpoint, older age, being male, obesity in general is correlated with tendon problems, ankylosing spondylitis specifically with Achilles problems. Fluoroquinolone use is associated with tendinosis, including tendon rupture, and then common training errors that you want to make sure you're always asking athletes about, including history of prior injury, abrupt increase in their activity or increase in intensity, or hilly running, poor mechanics, improper footwear, or a rapid change in footwear. So sometimes we'll see things flare up when people go from, running in trainers to running in spikes where they don't have quite the support that they did previously. And running in cold weather has also been linked to Achilles tendinopathy. From a biomechanical standpoint, and these are important when we're thinking about an initial rehabilitation protocol, decreased hip muscle strength is associated with tendinosis in the Achilles, decreased ankle plantar flexor strength, and decreased dorsiflexion range of motion. So the ankle things make sense, but the other piece to always keep in mind is those with weak hips have a correlation with Achilles tendinopathy. And from a personal experience, when I'm not doing my hip abductor strengthening, my Achilles starts to flare up. So that's a piece that we often miss in our runners who are running in a straight line. And you want to make sure you're not just focusing on the ankle region and the Achilles region alone from a rehab standpoint. Historically, from a pathophysiologic standpoint, we think of tendinopathy or tendinosis as recurrent microtrauma that causes what's called angiofibroblastic hyperplasia, not really an inflammatory process, but just hyperplasia of the cells with some fibrosis and blood vessel formation. Then the damaged tendons can become calcified, thickened, inelastic, fibrotic, and often we see neovascularization. Particularly with the Achilles, the pathophysiology, there have been some more recent theories. This was published in BJSM in 2023, and I think makes sense when we start to talk about some of the treatment options where with Achilles tendinosis and tendinopathy, we're getting swelling of the tendon, but that is related to a vascular pressure mismatch where we have some venous engorgement of the tendon in general, and the vessels become leaky, and we get some water substance within the tendon, and that contributes to, for example, the thickening that we see on ultrasound and some of the hypoechogenicity that we see on ultrasound. And if we can help somehow correct that leakiness of those vessels and kind of relieve some of the venous engorgement and pressure, maybe we can help treat these. So from a diagnostic standpoint, when we are imaging tendons, we think of soft tissue imaging with MRI or ultrasound. So MRI can be valuable in terms of identifying edema and a split tear that you can miss on ultrasound. It gives you a comprehensive evaluation of the joint. Occasionally, I've had patients present telling me that they had Achilles problems, and it was actually related to an osteotrigonum or something deeper. When you look at the Achilles and you talk to them a little bit more, their Achilles looked good, and on exam, that wasn't the problem. It was something deeper in the joint. So the MRI can be good in evaluating that. The downside is we all know delays. It can take a long time to get this. And as I mentioned, the runners want to be fixed immediately, as you all know, and the MRI can be expensive. So I prefer ultrasound, which can be used in clinic for diagnosis. It has superior spatial resolution, especially for superficial structures to MRI. You can dynamically assess the tendon if you're looking at a tear, or you can look for a dynamic assessment of the retroachilles and retrocalcaneal bursas on the tendon if those are also inflamed. You can assess for sonopalpation tenderness. So when you see an abnormality, you can push on it to see if it hurts. I often see abnormalities in Achilles tendons when I'm scanning, and you want to make sure you're calling the thing that's the problem. The downside of ultrasound is that it's operator dependent. So if you don't have training and aren't used to looking at these, there's a little bit of a learning curve, though for the Achilles, it is a relatively straightforward imaging. There have been studies that show that the accuracy between MRI and ultrasound in general is similar, so you could use either of these. From an ultrasound standpoint, the findings that we often see are thickening of the tendon, hypoechogenicity, intratendinous calcifications, and neovascularization. And there's actually a recent study, I've yet to apply this formula to my clinical practice, that looks at the average tendon thickness at the Achilles midportion and insertion. If we were to calculate these numbers, I'm sure they kind of fit with the gestalt that we have, where if you're seeing a lot of the other things, the other findings in addition to thickening. But it's interesting that now we do have some normative values, and in the tendons that they scanned, the tendinopathic tendons were thicker by 2.7 millimeters at the midportion and 1.4 millimeters at the insertion. On ultrasound, we also see neovascularization. There is a classification called the Oberg classification. So if you want to sound really smart, you can bring that up, but it's relatively straightforward in terms of it's a scale of 0 to 4, with 0 meaning there's no intratendinous neovascularization, 1 meaning there's some tendons just on the deep surface, or sorry, there are some vessels just on the deep surface. And then 2 meaning there's like 2 vessels going through the tendon, 3 there are 3, and 4 there are more than 4. So pretty straightforward scoring system, and sometimes I will use that in my notes so that I immediately can know kind of where we are on a spectrum of neovascularization. The thing to keep in mind, though, is you don't need neovascularization on Doppler to have tendinopathy. So there are 24% of symptomatic tendons in prior studies that have been found not to have this neovascularization present. And the presence of neovascularization in the De Jong study was related to function, but not actually to pain. So this in and of itself is a finding that we see on ultrasound, but it doesn't always correlate with how the patient feels. From an ultrasound standpoint, there are some newer imaging modalities that are still mostly research-based, but I figured that I would mention them here since this is a little bit of a higher level talk on Achilles issues. So shear wave elastography is one of the new tools that looks at the stiffness of the tendon. It uses Young's modulus to calculate the stress over strain. And the ultrasound beam will emit the acoustic forces, and the shear waves are the ones that propagate perpendicular to the ultrasound. And we're measuring these waves that propagate perpendicular, and that varies based on the density of structures. So the shear wave elastography gives us these color maps here. This is actually a patellar tendon. But in general, if it's blue, it's harder. If it's red, it's softer. Or sorry, in the opposite. If it's blue, it's softer. And if it's red, it's harder. And these are Achilles patellar tendon. And so this can look at the density basically of the tissue, mostly still being used for research purposes because, as you can imagine, there's some operator dependent to this, and there also are newer studies that show that the degree of ankle plantar and dorsiflexion can change the findings. And so from a clinical standpoint, this hasn't quite made it to clinic. Another ultrasound scanning modality that hasn't quite made it to clinic but is utilized in the research realm is something called ultrasound tissue characterization, which has been called the CT scan of ultrasound, or the CT scan version of ultrasound. So it uses this device that's standardized, that's just placed, and there is a standardized thing that moves the transducer and takes 600 contiguous images in 45 seconds. That goes at 0.2 millimeter intervals over 12 centimeters along the Achilles tendon. And it gets you this 3D block of ultrasound images that is generated based on the echogenicity and the pixels. So green in this scenario is stable. So a more normal tendon would look green, and then blue to red to black is less stability of the fibers. So this is a lot. But this was from a study on Achilles tendon in asymptomatic runners that compared trail runners to road runners. But just in general, looking at the ultrasound tissue characterization pictures, this is a cross section of the Achilles tendon, and then here are longitudinal views. So this green is a more normal appearing tendon versus this that is has more red, is more on the abnormal side. And interestingly, in this specific study, they found that road runners had more like blue and red in their tendons, so they were softer, than trail runners had more like normal looking tendons, which was interesting. From the standpoint of abnormalities in asymptomatic runners. So like I said, you have to be careful calling something, abnormal and contributing to their pain if you just see imaging findings. So this was a study by Cushman published in CJSM in 2022, where he scanned runners before a marathon and then subsequently at 1, 3, 6, and 12 months after. And they found that 24.6% of runners had asymptomatic Achilles tendon abnormalities, and 5% of those were bilateral. Then the positive predictive value for developing pain over a year was 31.8%, which is not super high, but if you did have a tendon abnormality, then, there was a roughly 30% chance that you would develop pain, versus if you didn't have an abnormality in your tendon, then there was an 88.4% chance that you were going to be okay, even though some people still did develop pain. The findings that they specifically looked at were hypoechogenicity, blurring of the peritoneum, intertendinous calcification, and then osteophyte and thickening of the tendon. And it doesn't seem like any of these, significantly correlated with development of pain. I think we were hoping that we would find, if we always see this thing, those people are more likely to have pain, but that was actually not the case. All right, so I brushed through kind of the background pretty quickly, and we'll spend a lot more time talking about management. So here's the list of the laundry list of treatment options for Achilles tendinopathy. And I always tell my patients anytime we have a bunch of options for treating something, we don't have one great thing that's always going to fix it. Though I think we have one mainstay of treatment in treating Achilles problems. When we're thinking about treatment options, and this isn't something that I belabored because I kind of skipped over the basics of Achilles problems, but you know, insertional Achilles tendinopathy and mid portion Achilles tendinopathy often tend to respond differently to treatments. And in general, and we'll review a little bit the treatment options, insertional Achilles tendinopathy is much more resistant to treatment. So from a non-interventional standpoint, most of the time, by the time patients get to me, they've tried rest, ice, probably have taken some NSAIDs. Whether or not those are what we should do in tendinopathy is still kind of up for debate, and may have taken Tylenol. Um, a lot of times I have patients come to me and say that they've done physical therapy or physical therapy related exercises and they haven't helped. And the PM&R training background in me always asks them exactly what they did, because you would be surprised how many people go to therapy and don't load the tendon once. So they're probably not going to be getting better. Other treatments for tendon problems, nitroglycerin patches, though, have been less well studied in the Achilles. Acupuncture, there's actually a study on acupuncture in the Achilles that shows significant benefit. I personally have never referred a patient for acupuncture for Achilles tendinopathy, but maybe I need to, based on that study. Shockwave therapy, which we'll talk in a little more detail about, and then orthotics or heel lift, or taping, just to try to offload the tendon a bit. And a lot of my patients have tried some form of that as well before they get to me. In an extreme case, or if you're worried about acute tendonitis or a tear, you can immobilize for a short amount of time, but the Achilles tendon needs significant load. So I caution people from putting someone in a boot for a long amount of time. So non-interventional treatments, if those are not working, then we can move on to interventional treatments. And options there are multiple, and I divide these into extra tendinous procedures, which are the first two. Can be intra or extra tendinous procedures, which are any of the orthobiologics, and then intratendinous procedures. And I make that distinction mostly because the amount of downtime that runners have to take after those varies significantly, whether you're going into the tendon or if you're staying outside the tendon. And whether that's needed or not, that's kind of been the convention. So high volume image guided injection, we'll talk a little bit about this, but in general, that's an injection done under ultrasound where you put a lot of sterile saline between the Achilles tendon and Keger's fat pad. And you can do that with or without corticosteroid. I personally have never put corticosteroid anywhere near the Achilles tendon, and I have no desire to, because the last thing that I would want is someone to rupture their Achilles. But a lot of people have done it in research and no one has reported ruptures. So maybe it is safer than I think. The tendon scraping procedure is also an extra tendinous procedure that involves mechanical debridement with a needle or a meniscotome on the deep surface of the Achilles, separating it from Keger's fat pad. And I'll talk a little bit more in detail about that. I'm not going to talk in detail about any of the orthobiologic injections. I think, if we're thinking about options for future talks, that in and of itself could be an entire talk. These are not typically my first go-to, primarily from a cost standpoint, and we'll talk about my usual algorithm in a bit. Needle tenotomy, where you use a needle and poke tiny holes in the tendon repetitively with just a needle, or there are many, I call them device tenotomies, whether that's the correct term or not, that several companies have specific devices designed for intratendinous debridement, which I have done more as like a last line treatment for Achilles problems with pretty good success. And then if all of those things fail, we send them on to the surgical colleagues for consideration of an Achilles tendon debridement, and often that occurs in the setting of insertional Achilles tendon issues where they also have a Haglund calcaneal deformity. So exercise therapy is kind of the mainstay of treatment. I skipped some slides, maybe. Yeah, well, we're going to start with exercise therapy. This, in my mind, is the mainstay of treatment. Everyone should be getting this as part of a prescription from either you or from a physical therapist who is used to taking care of runners. The most common reason that I see people are not getting better from Achilles problems is because their rehab program is not sufficient. And here I am doing the thing that I said not to do and only showing images of loading the Achilles tendon. But the first step is making sure that they're doing core and hip abductor strengthening as part of their regimen. Um, from a direct Achilles tendon loading perspective, we think of eccentric versus heavy, slow, concentric exercises. This study by Bayer and AJSM in 2015 did not show a difference between the two, but showed that the heavy, slow concentrics were better tolerated and also took less time in a week to perform. Typically, I'm having my patients do, and I instruct them on some combination of the two. Excuse me. But the biggest thing to keep in mind anytime they're doing either regimen is that you need to be performing the action slowly, and you need to perform everything with both a straight knee and a bent knee. And that is because we're isolating the soleus more with a bent knee and the gastroc with a straight knee. The other pro tip for Achilles exercises, if you're doing eccentrics, is if you have a block here to help you raise back up, you don't have to use your other foot to go up on your tiptoes. So that can be valuable if someone has bilateral issues. And the other tip with the eccentrics is if someone has insertional tendinopathy, you don't need to do this off of the edge of a step, off the edge of a step for mid portion, but not for insertional. And the heavy, slow concentrics here, they describe them with machines. So with just the calf raise machine with a leg press machine where your legs are straight, and then a barbell. But you could also be doing those with dumbbells in your hands. Or one of my favorite things when people tell me they don't have weights is most people still have books or something heavy that they can put in a backpack in order to load the tendon. So this kind of is the mainstay of treatment. And some of these studies, when I ask what treatment is best, are going to show this. So there have been a few meta-analyses in the last several years. I guess some of these are becoming a little bit dated. And this first one is looking at mid-portion tendinopathy, and this is a busy slide, but I will walk you through things. So in this study, they looked at different treatments at 3 months and then at 1 year and compared them. And this was all looking at the Visa A score with a 95% confidence interval reported. And anything that has a negative value meant that the treatment on the top was better, and anything that had a positive value meant the treatment on the right was better. And the thing to note about this is literally anything was better than wait and see. So every patient that comes into your clinic who is like, I just took, 3 months off and didn't do anything like that, is literally any other treatment we have is better than that. And in this meta-analysis, actually shockwave and acupuncture were better than exercise therapy and a placebo injection. And exercise therapy alone, and exercise plus shockwave is better than those alone, or better than shockwave alone, and acupuncture is better. And there were very few studies that included acupuncture and the exercise and shockwave portions, but those studies were positive for those treatments being helpful for mid portion. And then looking at the 1 year point, not many studies had data out to that point, but there was nothing that was significant over other treatments. Another busy slide, also looking at mid-portion tendinopathy. This was a network meta-analysis with slightly different methods. The other thing to keep in mind is all of the studies included in this had high risk of bias. And so in these graphs, anything that's not crossing 0 is something significant favoring the intervention. In this specific study at the less than 3-month standpoint found that eccentric exercise with the high volume image guided injection and a steroid was superior to exercise alone. And the same thing with acupuncture was superior to exercise alone. And notably, this eccentric exercise with high volume injection without steroid was not helpful. And then looking at data in 3 to 12 months, here again, we see the wait and see is not beneficial. But eccentric exercises with shockwave and then acupuncture were helpful. So slightly different methods coming up with similar activities. And then this chart, which I thought was an interesting way to look at it, was looking at the tolerability of the activity and whether they were going to continue to do it or whether, people had adverse events, and basically like nothing was significant. So it's not like, hey, definitely don't do this treatment because patients, couldn't tolerate it at all. Looking more at insertional. So now all of these, again, anything that's not crossing 0 is significant. And the only thing here that was significant for insertional Achilles tendinopathy, not looking at procedures so much in this study, but the only thing that they found was eccentric exercises with soft tissue manual therapy was helpful compared to wait and see. And they looked at laser, shockwave, and whole body vibration, but no interventional procedures in this meta-analysis. All right, so I just sped through a lot of highlights on Achilles tendinopathy, and now we're going to talk a little bit about my treatment. And this is keeping in mind that runners want to run. So if you see a bunch of runners and first thing you recommend is a treatment that's going to keep them out for 3 months, they're probably not going to go through with it. And it's also probably not the best place to start. So as I mentioned, exercise therapy is key. You need to make sure you're targeting the core and the hip group, as well as having targeted exercises at the Achilles, whether that's eccentric or heavy, slow, concentric. And then when you're doing those, you want to make sure that they're increasing weight. That's the other thing that I see where people are not doing well. And it's because they've been doing body weight Achilles exercises, for months. And when you put it in this way, where I usually tell them, like, how much force goes through your Achilles tendon when you try to run? That's why it hurts when you run. You're only putting your body weight through it when you're doing your therapy exercises, and then you try to put multiple times that through it when you run. There's a reason why, you can do the exercise and you can walk around without pain, and then it flares up when you're running. So most of the time I find that people aren't doing hip abductor exercises and they're definitely underloading the tendon, and that's why they're not getting better. And I'd say probably 90% of the people I see, if I can get them to do those two things, we often don't need to go and do anything else. I'm usually having them run as tolerated. Tendons need load. In general, there's actually a recent study that I didn't put in here, but it showed that the tendon doesn't actually break down while you're running. It's breaking down after as part of the recovery process, which was an interesting finding. We're not exactly sure, what we need to be doing, but if people are able to run and they're not having worsening pain after or during, and it's gone by the next day, I typically let people continue to run. One of my favorite, instead of like a heel lift, is something called a silicone Achilles sleeve. You can buy them on Amazon. This is not backed by research, it's backed by personal experience. But the sleeve has like a silicone pad over that goes under the heel to give it a bit of a lift, and then in the back over the Achilles tendon, and almost acts like a sock. I do see some people who have changed shoes or other things and they're getting pressure related irritation to the back of the tendon, or they have a prominent bump from having Achilles tendon issues in the past, and so this silicone sleeve can take a lot of the pressure and the stress off of that. I also typically tell patients that they can continue with any modalities that they feel like are helpful. So foam rolling, you know, uh, massage, that kind of thing. If they think that it's valuable and is helpful for them and they want to pay for something, it's probably not going to cause any harm. Um, and then if we're, taking a step beyond the more basic things, shockwave therapy, and tendon scraping are two things that I recommend, and I'm going to talk a little bit more in detail about that. Also, prolotherapy for insertional issues, that's extra tendinous, is something that I will often go to quickly, and it's because all of these treatment options require minimal downtime and minimal time away from running. I'm going to leave this here if people want to take a screenshot or at least go back and read the paper. This is an article that was recently published in CSMR looking at interventions for managing Achilles tendinopathy in the in-season athlete. So not specific to runners, but they do highlight two treatments that I really like, and it does detail a lot of the treatment options for Achilles tendon problems. So if you're not familiar with these, this is an excellent article to kind of take a look at. They talk about how they do the different procedures, how long they have people rest, and things like that afterwards. All right, so we're going to talk about shockwave and tendon scraping in a little bit more detail. So shockwave therapy is where we send either acoustic energy and focus shockwave or pressure waves and radial shockwave and try to stimulate some healing. And there are multiple different proposed mechanisms for how this is working. Break up adhesions, stimulate some healing, effects on substance P, which modulates pain. But shockwave is has minimal downtime afterwards, so I find that it's very valuable. And the focus shockwave is a device that looks more like this. Typically, this is done by a physician, and you need to have some sort of imaging that's guiding you because you have to adjust the depth of this focal point. So the waves start out more convergent or divergent and converge on a specific target, and you set the machine to determine you set the machine depth to make sure that it's at the proper target. So this is usually performed by a doctor. Radial shockwave is often performed by a physician, but also I have chiropractic physical therapy colleagues that perform radial shockwave, where radial shockwaves are sent out and they diverge before they get down to the target structure. So the maximum point of density is more superficial. And as we get deeper, less superficial or less strong with radial. There have been many studies published on shockwave in general. I just wanted to highlight this one. This is from Adam 1040's group that was published in PM&R and specific to the Achilles tendon. And they had a large percentage of people in this cohort who were runners. So they were looking at radial shockwave alone versus combined radial and focused shockwave. And in the radial group, they had 60%, almost 70% runners and a little over 80% in the combined group. And they were looking at the number of runners that met the MCID for insertional, which was 7, and mid portion, which was 12. And that was significantly different between the combined and radial. So everyone was getting better. So from baseline to final, and you can see the change in MCID here, looking at all tendons. So both of them helped, but this was showing significantly that combined radial with focus was more helpful. I think it's most common for people that aren't doing a lot of shockwave in general to have radial devices to start, particularly because they're much less expensive. So not everyone has access to the combined, but that is probably the most ideal if possible. So shockwave implementation, and this is from Dr. 1040, who does a ton of shockwave in runners. And this is what I usually recommend to my patients, where you're doing at least 3 sessions weekly, once a week for 3 weeks. And I tell them that they can continue if they're finding it valuable, but they're not completely better. Usually combining the focus and radial is most ideal. If you only have radial, I have seen a lot of runners get better with just that as well. And the study showed that they use a what's called clinical focusing technique, where you're doing it at the site of the patient's pain. From a radial standpoint, from a focus standpoint, it is nice to at least have some measurement at the depth of the Achilles, um, to guide you a bit if possible. Usually this is done without anesthetic, and I typically tell patients that they can run as tolerated while doing this. I usually recommend that they run in the morning before they were to get a treatment if they wanted to run that day, and then not run until the next day. There has been one reported case of Achilles tendon rupture with shockwave in the literature, and that was in an elderly female. And so maybe we need to be a bit more cautious in some elderly population that have a tendon that looks pretty abnormal from a rupture standpoint, but it's probably likely that that tendon was at risk for rupture, whether or not the shockwave was utilized or not. So lastly, we'll talk a little bit about a procedure called tendon scraping. And if I'm doing something interventional, this is my go-to favorite. This procedure was initially developed by Alfredson, who developed the eccentric exercise protocol, with the same kind of concept in mind. So for this procedure, he initially did it open, or where he went deep to the tendon and basically scraped the deep surface of the tendon away from Kager's fat pad. And if anyone's ever looked back at the eccentric exercise literature from the beginning, the goal was to shear the tendon away from the fat pad below, because it was thought that those adhesions were contributing to pain. And now that we have ultrasound, and I'll show some pictures of this, we think that some of the neovasculature comes from the fat pad and those adhesions happen. And it's possible that some of that venous engorgement that I talked about happens because we're not able, like the blood flow is not leaving the tendon in the manner that it used to, as well as neonerves grow with those neovessels, and those are what can contribute to pain. So anything that's targeting the exercises are targeting kind of shearing Kager's fat pad away from the Achilles. Um, and so is this procedure. So he initially did it open, and in this was his second study. He had a cohort of 88 patients, where he did this open procedure, and then he did a RCT comparing the open procedure to an ultrasound guided procedure where he used a needle and the ultrasound to basically do the same thing, where he's separating the anterior side of the tendon from the fat pad under ultrasound guidance. And after this, he had a much more conservative rehab protocol than what I and most of my colleagues use now. But basically, by 2 weeks out after this, they were kind of getting back into running, which was very quick for a procedure on the Achilles, when before this was developed, the surgical procedures for this were, 6 months out, basically. So as I mentioned, he did the randomized controlled trial, and he did not see any difference between the mini open and the percutaneous treatments, and all of them significantly decreased the patient's VAS. This is on a scale of 100 being very painful and 0 being nothing. So you can see that significant decline. That's very drastic, and there were a few patients who were not satisfied overall. But in general, that drop in VAS was pretty significant. And the big thing to note is the ultrasound guided procedure seemed to be similar to the procedure done with open surgery. He then published a study a few years later in 2016, where he was looking at 519 tendons. And this was specifically at the mini open, because that's how many he had done at the time. And it included a large cohort of people from inactive to very elite athletes, and many runners or track and field athletes. The rehab protocol was the same as what I mentioned before, and he found only a 5% recurrence rate at 1 year. And that occurred in 26 people. And of those 26 that it occurred in, 18 of them were completely inactive. So only 8 athletes had a recurrence in the study. So this procedure, in and of itself, I'll like explain a little bit of the Achilles tendon anatomy from a diagnostic standpoint, and then the procedure. So this is looking at a left Achilles tendon. On the left side of the screen is distal. So this is the calcaneus. Here's the tendon, and you start to see it getting thicker at this location. And then this is a little more proximal to where I was at. Here is an intratendinous calcification. That's that same calcification here. So a lot of the findings of Achilles tendinopathy that I talked about where we have hypoechogenicity. So that hypoechogenicity means it's darker, significant thickening. It should be about this thick, even more proximal. Intratendinous calcifications. And then this is a short axis scan through. This is calcaneus here. Maybe this will play. Yep. And now we're going proximal. And you can see how thick that tendon gets and hypoechoic. And here's a little calcification. It's kind of going slowly, but like multiple intratendinous calcifications there. I'm going to keep going. And then here's a color Doppler image, and this is probably what I'd call like an Oberg of 1. You eventually see a intratendinous vessel here, but you can see them deep in. So Keger's fat pad's deep. This is Achilles tendon. So the scraping procedure, I'll use local anesthetic with a 27 gauge needle. And then you can use a number 11 blade to make a stab incision if you're using a meniscotome as well. But often I just do this with an 18 gauge needle from a cost perspective. And some sterile saline, just 10 to 20 milliliters. The high volume injections that I talked about, they use 40 to 50 mLs of fluid in those. So this is significantly less. From an entry point, you can come from either the medial to the lateral or the lateral to medial side. I actually prefer medial to lateral because the tibial vasculature is much farther anterior than your entry point. And when you're coming on the lateral side, you have to watch out for the sural nerve. So if I come medial to lateral, then I don't have to worry about that too much. So this is an example. This one was actually with the meniscotome. So this is the meniscotome deep to the tendon. And you kind of just do this like back and forth swiping movement. And as you're doing it, you can feel adhesions and you basically keep going back and forth, sometimes posterior to anterior, up and down until you separate the deep part of the tendon away from the fat pad. All of my videos are playing very slowly, so I'm going to keep going. And then this is showing the injection at the end. So when we inject the fluid, you can see that fat pad, we've kind of separated it away, and the fat pad, and you can see that separates both proximal and distal. The place that I target is usually the place with the thickest or most neovasculature. And sometimes I will make 2 entry points if I can't get proximal and distal enough. And the other thing with this procedure, usually I'm using an 18 gauge 1.5 is runners are skinny. You don't want to be like poking through the other side. So you always need to be aware of where your tip is. And you always want the bevel of the needle facing down, so that you're not scraping with the sharp portion of the needle into the undersurface of the tendon. So post-procedure with this, they weight bear immediately. I let them go back to running the day after the procedure as tolerated. Usually this results in pretty rapid improvement of pain. I usually caution them not to go crazy if they're feeling good. So if they were not running at all, I don't want them to run the day after the procedure. And if they are, it's going to be a gradual progression starting with a walk run with like 30-second to 1-minute intervals of running. Because what you don't want them to do is feel too good that then they subsequently, do too much and are putting load through the tendon that the tendon is not ready for. If they've been running like they're like, oh, I usually run like 40 miles a week, but I can run 15 miles a week and it doesn't bother me too much, then they can start back at the 15 miles a week and gradually progress from there. Afterwards, they can shower, but I don't want them submerging underwater for 2 days. That's from an infection risk standpoint. And they can take, over-the-counter medications as needed. Usually, in most of my patients with chronic tendon problems, I have them avoid NSAIDs, unless they're doing a short course, like in a flare-up. All right, so back to my case. So this person said she had tried everything conservative, didn't want to take time off, but she was treated with a tendon scraping and made it to her marathon 16 weeks after I saw her. So in summary, anatomy of the Achilles tendon probably does play a role, and it has this slight twist to it. From a rehab standpoint, we have to think about the biomechanics with always remembering the hip abductors, and we need to make sure that we're loading and stretching. I kind of, didn't mention that too much, but we got to load and stretch those plantar flexors. Ultrasound is an extremely valuable diagnostic tool, especially in clinic. Runners love information. We're all nerds. We all wear watches and want to know everything that's happening all the time. And it's the same way with the tendon. So if you can show them what's going on, explain to them exactly what's going on, I feel like that just like calms a whole level of anxiety. And then from a treatment standpoint, I like the things that cause the least amount of downtime to start. And if those aren't working, then we can move on to some of the more aggressive and invasive procedures. All right, I went a little tiny bit long. Here are some references. Oh, and then we can take questions. I think my son wrote those Q58s. He was typing on my computer earlier, so sorry about that. This guy, he can type things because he sees me do it.
That's a good story. I like it. Well, Dr. Schrader, this is a fantastic overview and lots of good, updated, evidence-based treatments. I do think Achilles tendinopathy is always a challenging topic because there are so many things that we can
Mhm.
talk about for treatments that we don't have any one specific way to do it. Sometimes I feel like it's like talking about reds, where there's so many things for us to talk about. So, um, so for those who are joining us a little bit late, this is Running Medicine National Grand Rounds. I'm Sara Raiser, coming to you from University of Virginia Runners Clinic, and we are wrapping up with Dr. Schrader's talk on Achilles tendinopathy. I do have one question that came through in the chat, and then I've got a couple of questions too. So one question that came through in the chat was asking about shockwave for mid-substance versus insertional.
Mhm.
Do you have any thoughts on treatment for both of them, either of them?
Yeah, so it has been used for both, and that study that I showed by Dr. 1040 said that it was valuable for both of those. When you look at the like meta-analyses for insertional, it's not quite as good. Like it's probably much more reliable for mid portion, but there is some data and evidence that it's helpful for both of them. It is something like when someone comes to me with insertional issues, I kind of set their expectations right off the bat where this is a hard problem to deal with. And, we are going to kind of throw everything at it, starting with the least invasive and kind of see what sticks. Whereas mid portion, I give them a little bit more hope of like, this is definitely going to get better. Like most people with mid portion Achilles problems feel better at some point, and then, a lot of times we lapse on our exercises or things and it comes back. Whereas insertional, I'm not quite as optimistic because it can be a lot more stubborn.
I certainly find I'm trying to send folks to address the haggling and other things for insertional. I agree. It's a little persnickety.
Yeah.
Um,
Yeah, that's something I'll move to like one of the device tenotomies, um, sometimes a little bit sooner than later. Usually I try the other things first because people do get better with them, and if you can save them the downtime, like I mentioned, but I find that I'm moving on more with that.
uh, shoes. Do you have
Mhm.
any opinions on shoes? I know folks are always asking, well, what should I be in? Is there a particular shoe that I should be in if my Achilles is giving me trouble? What are your thoughts?
Yeah. I mean, the only thing we know from like a data standpoint that takes the load off the tendon is probably the opposite of what the trends are, but a high drop shoe is going to have less load through the tendon. I find people get into trouble when they go from a high drop shoe to a lower drop shoe and have more load through the tendon. But my personal opinion, and maybe this is just me being uh biased and trying like a million different shoes to figure out what works for me, is that everyone's feet are slightly different and you need to find the thing that works for you. And the stronger your feet are and the stronger your calf and Achilles are, the more likely you're probably able to jump from shoe to shoe and not have issues. Um, so usually I tell them that there's no like one size fits all. I know some people have like strong opinions of like Hoka versus barefoot running. And I think there are some people that Hokas are great for, and there are some people that they're terrible for, and there are some people that ultras are great for, and there are some people that they're terrible for. Um, so it's usually more like a much more individualized discussion rather than a blanket statement.
Agreed, it depends.
Yeah.
Um, One question that I've had come up a few times in clinics, I'll pose it to you. Collagen supplementation. I get the question all the time, what do you think about taking oral supplementation while I'm trying to get my tendon to heal?
Yeah. My, I mean, there is some data that collagen supplement does help tendon problems. And my personal opinion for any of those things is if it's not going to harm you and you think it's going to help and you're willing to pay for it, you should try it. Because we also know that there's like a 30% placebo effect of like literally any treatment that anyone does. So if someone is convinced that this thing is going to help them, there's a 30% chance that it is, even if it actually, you know, has no scientific basis to benefit them. So you know, as long as they're not doing something that's going to harm them. I once had a patient who told me she was getting a treatment where they drew her blood and put it through a UV filter and then put it back in. And I think that was probably one of the few times where I was like, you probably should not do that. Um, for her, I think she actually might have had Achilles tendon problems. I can't remember what her issue was, but I was like, that's not great. But collagen supplements, probably low risk, cost money, worth
Yeah,
trying.
you say the biggest hurting's on your wallet.
Yeah.
Um,
Is that your feeling too?
Yeah,
Yeah.
I give the same kind of spiel. I was actually impressed the first time I looked that there are some
Hmm.
studies on collagen supplementation, which is great. I need to do a little bit more combing to see what's more specific. But yeah, I agree. I think the risk is pretty low, unless folks have really complex medical histories. I think it's pretty reasonable. And usually when we're getting to that point, I'm working them up for some reds and overtraining things and seeing if we need to
Yeah.
get them with dietitians because they need the building blocks to be able to heal and the energy to heal. And so oftentimes when they ask that question, I'll start going down that route too. I certainly think those are closely tied.
Yeah. Yeah. I mean, that was one piece that there were so many things we could talk about with Achilles tendinopathy, and I
So
figured there
many.
was going to be an entire talk about that, for sure. So, but that's the other piece, and in any runner is we need to make sure that they're fueling and not developing recurrent issues related to underfueling.
So I have a few more questions that are rolling in here. So one question, with tendon scraping, we disrupt the neovascularity and its outline can affect the venous flow to the tendon. Assuming a multimodal treatment plan with gait changes and therapies, do you often see a need for additional treatment progression after scraping?
Typically not. It's kind of crazy how quickly people feel better. I would do the same progression that I'm doing, like if someone hasn't been running much, like a return to run following that procedure. And if they have been running, then a gradual progression based on like, typically try not to increase by more than 10% of your miles per week. Make sure you're not changing other factors, not changing intensity when you're changing mileage, and those types of things.
Any theories as to why cold weather running is associated with Achilles tendinopathy?
Yeah, I mean, this has been shown in studies that it's associated. I think it probably has to do with tightness issue. Um, but yeah, I think that's the theory.
And heat on the other end of the spectrum as well.
Hmm.
Um, it was interesting how you mentioned that road versus trail runners had different characteristics of their Achilles. Wondering whether you use that information to counsel patients, and if so, whether switching surfaces has noticeably benefited patients.
So I have not, but maybe I should start. But I worry that it's more of an association rather than a correlation where the things they didn't look at in the study were like what pace they're running, and that kind of thing. And in general, what footwear they're wearing. I feel like in general, road runners are probably running at a faster pace more consistently. Whereas if you're on trails, it's a little bit slower because they're more technical and your stride pattern is probably drastically different on a road versus a trail. And usually trail runners are probably like cadence wise at a higher cadence because you're taking more steps just to keep from falling. So I think there are probably a lot of factors in there. So I haven't specifically used that, but I do think it's a very interesting piece of information that we probably need more research on.
Well, this worked out perfectly. It's exactly 8 o'clock, so we can respect everyone's time this evening. Thank you so much for all the questions. Thank you, Dr. Schrader, for your wonderful talk. I think you did a really great overview, and in 45 minutes, it's a tough thing to do. So thank you so much for hanging out with us this evening. I had a good time chatting with you as well. So, and thank you to everyone who took the time out of your evening. This will get posted onto the UVA Runners Clinic YouTube channel. So if anyone needs to take a look back at things, or if you have friends who might be interested, please do share the wealth. And we'll plan to see you most likely in February next year. I think we're most likely going to take January off. So everyone have a wonderful holiday and good night.